Welcome, everyone. Thanks for making the time to be with us today. We're going to get started in just a moment. Well, hi, everyone. I'm Michael Morella, Managing Editor at US News and World Report. In today's session, we're going to be examining the promising new era in treatment for neuromuscular diseases. Before we get into our live panel, we do want to show you a video from a recent conversation that my colleague and US News Managing Editor Liz Whitehead hosted with Dr. Caitlin Batley, pediatric neurologist and director of the Pediatric Neuromuscular Program at Children's Health and an assistant professor of pediatrics and neurology at UT Southwestern Medical Center. Let's take a look.
We're grateful to have Children's Health's Dr. Caitlin Batley join us to discuss an important advance in treating Duchenne muscular dystrophy, which holds the promise for being a game changer in the lives of many children fighting this disease. Thank you, Dr. Batley. Can you begin by sketching out a bit about what Duchenne is, whom it affects, and how Duchenne's manifests itself as a child gets older?
Duchenne muscular dystrophy is the most common muscular dystrophy in boys, affecting about 1 in 3,500 to 5,000 boys. It is a genetic or inherited muscle disease that affects the DMD gene, which makes a protein in the body called dystrophin. Dystrophin is important for helping to stabilize the muscle, and without it, the muscle undergoes progressive breakdown, eventually leading to weakness of all muscles of the body. This disease is inherited on the X chromosome, and that's why it particularly affects boys, because boys have 1 X chromosome, whereas girls have 2. Although there are some cases where females are affected with similar symptoms as well, it typically is affecting boys. And so usually boys with DMD will be diagnosed around the toddler school age years, when symptoms of muscle weakness become a little bit more noticeable, even though the disease is present from birth and has been affecting the muscles throughout the lifespan. But around that toddler school age time is when parents or teachers might notice that maybe they're a little bit clumsier than their peers, maybe falling a little bit more or having trouble standing up from the ground, sometimes also developing muscle pain. And usually that's what leads them to seek medical care, usually a referral to their pediatrician, who will check a muscle enzyme level and notice that it's elevated, which indicates, signs of muscle breakdown, and then ultimately referral to a neurologist typically, or sometimes a geneticist. And that's typically how the diagnosis is made. And then from there, pursuing treatment.
Is it pretty widely understood by pediatricians to test for DMD with these kinds of symptoms?
That is always the hope, because a CK level or a muscle enzyme level is something that can easily be checked in most laboratories. And it's, an inexpensive test to run as well. And so that's a really good screening test. And so we hope that, all primary care providers who see, especially a boy, but any patient who looks like they have muscle weakness would check that test. And so it's fortunately picked up by a lot of pediatricians early on.
So what have been the traditional treatments, or as they've evolved over the last 20 years, for Duchenne, and what success have the traditional treatments had? What have you been able to do?
So over the past couple of decades, the mainstay of treatment for boys with Duchenne has been the use of corticosteroids. These medications are thought to decrease inflammation of the muscle and slow muscle breakdown. We know from some of the early studies that these medications can be helpful in delaying the time to loss of ambulation, which is a really big milestone in Duchenne. And in doing so, we know that boys who are remaining ambulatory longer are less likely to develop severe scoliosis that could require surgical intervention, and that they'll also delay the onset of respiratory muscle decline as well. And so historically, we have been using these medications in Duchenne muscular dystrophy as the first line of treatment. However, these medications can come with potential side effects that can limit the way that we're able to use them. So because of the side effects of these medications, we typically try to weigh the risks and benefits of their use. And so often don't start treatment until a boy is showing signs of proximal muscle weakness, even though we know that the disease has begun at birth. And so with that said, we've got this time period where we're not providing any treatment and we're kind of watching and waiting. And so the question is, should we be, treating these boys earlier? But as it stands right now, because of the potential side effects of these medications, we typically wait a little bit longer. And these side effects can also lead us to have to adjust doses. Maybe a boy can't tolerate the full dose that's recommended because of side effects. And then there are some families who choose to forego steroid therapy because the side effects can be so severe. So although we know that these medications are beneficial, there still is a great amount of unmet need in the DMD community for newer therapies as well.
Right, which is why the research into gene therapy is so exciting right now. So the FDA recently approved, I guess, the first gene therapy for Duchenne. What mechanisms is it targeting for the disease, and how is it administered?
Yes, it's a really exciting time to have this new therapy to be able to offer to some of our patients. So the medication is a gene transfer therapy. And so what it is a transgene, which is a kind of constructed portion of the dystrophin gene. Unfortunately, the dystrophin gene or DMD gene is so large that it's not able to be completely fit inside of the mechanism to administer it, which is called a viral vector. And so the designers of this drug had to pick which portions of the DMD gene they thought would be most beneficial in helping to maintain muscle function, and so create what they call a microdystrophin. And so in doing so, we know that this is not a full-length typical dystrophin protein that's being provided. It is still a shortened protein. And so we know that this medication still would not be considered a cure. But the hope is that by providing the body with this kind of instruction manual to make this better dystrophin protein, we are able to give these boys the tools that they need to help maintain their muscle function and drastically change, the outcomes of this disease and what it looks like into the future. And so right now, this medication is given one time through an IV infusion, and then the subsequent follow-up that we have to perform to make sure that we're monitoring for safety and all of those things goes on long after that one-time infusion.
Have you seen any side effects?
So the most common side effects of this therapy are around the time of infusion. Typically can be, some fever, nausea, vomiting, and that has been seen in many boys in the clinical trial and in boys who've received the drug commercially. There's potential for more serious adverse events, however, and that's why we take the administration so seriously and have a well-established monitoring protocol. We know that when we are administering this medication, we are kind of giving a foreign material to the body, and the body's job is to, recognize something as foreign and then to be able to, attack it to protect the body. And that's the mechanism for how, we come into contact with cold virus and we're able to fight it off and recover. And so because of this, we know that the body can respond to this viral vector that we're administering this therapy through and create a large immune response. And in trials, we've seen that this can cause inflammation, particularly of the liver, and so potential for liver injury. And it can also cause inflammation of the heart muscle or myocarditis. There's also been instances where part of the immune response called complement gets activated and can cause injury to the kidneys. And we've also seen that this medication can cause the host's immune response to attack the new foreign protein in the muscles and actually cause weakness of the muscles from that. And for that reason, there is an exclusion on the prescribing information that boys who have a certain kind of genetic change or a deletion of certain parts of the gene called exons 8 and 9 should not receive this medication right now because of the potential for that risk of immune-mediated damage to the muscles called immune-mediated myositis.
Except for this exception, would it be accurate to say that many of these side effects are treatable and manageable, hopefully?
Yes, and so that is the reason why there is such close laboratory monitoring. We have our boys come in for lab draws at least once a week, sometimes more depending on what's going on, in order to be proactive to make sure that we're monitoring all of the different organ systems. So that way, if we are starting to see a response, we can, act promptly and try to prevent any downstream complications. So right now, we are hopeful that any boy who does have an adverse event will be able to intervene quickly and minimize it as much as possible.
So you treated your first patient about a year ago. Can you talk a little bit about him? How old was he at the time, and where was he developmentally?
Yeah, of course. It was really exciting. Just over a year ago, we treated our first patient. He was 4 years old at the time, and he had been diagnosed actually as a baby because of family history. And so his family had kind of always noted that his motor skills were a little bit behind that of his peers. And he was starting to show some signs of muscle weakness, some of that trouble getting up off the ground, and he wasn't able to run or to climb or jump. And so, he received therapy about a year ago, and he did just fabulous. He had very minimal side effects from the medication itself and completed all of his follow-up monitoring protocol and is now back on his kind of baseline dose of steroids. And throughout this past year, we've seen some improvements in his motor function. He's learned to run and he's climbing now. His parents even say that they've had to kind of child-proof more things high up on their cabinets and that kind of thing, because now he's getting up and into everything because he's just much more active. And they've noticed that he's able to play more like a typical 5-year-old now. And so it's been a really exciting thing for us in clinic to watch, and then of course for his family as well. And I think that just gives us this indication of how hopeful we can be. This is a relatively short time period, 1 year, and at a time period where we still wouldn't expect to see the most severe consequences of DMD. And so I think the future is really what we're excited to see, the differences and the changes that this little boy can see compared to what we might expect in an untreated patient. And so the next couple of years, I'm hopeful, will be very exciting for all of us.
Yeah, I mean, what's striking is you're not just talking about slowing the progression, the negative progression of the disease, but actually you've been able to reverse it.
And so, in the way that he's gaining more milestones and he's able to do things that he wasn't able to do before, we are seeing things that, have never been reported before in DMD. We do know that some of the muscle changes that he'd already experienced, such as the replacement of his good muscle tissue with fat and scar tissue, those kinds of things are not totally reversible, but we're hoping to maintain the muscle function that he did have at that time, and then allow him to, continue to make motor progress.
So Children's Health, and I guess, is it a few centers around the country are participating now in trials? Are the trials going to be expanded? What do you see in the next couple of years?
Definitely. So trials are ongoing for this medication, to look at its use in different kinds of patients. And so specifically some of our older young men and those who might no longer be ambulatory, or those who might have more significant complications of the disease, such as already having heart muscle involvement called cardiomyopathy. And so those studies are ongoing, so that way we can have that information in order to better guide our patients on whether or not this medication might be right for them. There are also other companies who are developing their own gene therapy products, and so there could be potential for more options in the future. One of the limitations of using these medications is that any boy who already has pre-existing antibodies to this viral vector that we use would not be eligible at this time. And so there are other companies who are looking at the use of gene therapy with different viral vectors that potentially one boy who might have pre-existing antibodies to one might be able to receive the other. And then there's also discussion of how we can possibly remove those antibodies so that way a boy can still be treated with these medicines. And so, you know, the one kind of universal feature of researchers and families in this community is that they do not give up and will not rest until there is a treatment for all of our boys and young men. And so, you know, this medication is an option for a lot of people, but not for everyone. And so there is still more work to be done.
Right. And the hope, as you said, that a lot of people are trying to attack the disease from different directions, you know, the gene therapies to make some of these adjustments to get this larger pool of patients with their own distinctive characteristics. You had mentioned that there's a small number of girls who may present with these symptoms. Is there any possibility they would be eligible for this treatment at some point?
Yeah, that's a really interesting question. To my knowledge, there has not been a girl who's been treated with gene therapy. But interestingly, the prescribing information for this medication does state that an individual with DMD is eligible for the treatment and doesn't actually specify sex. So that is interesting and could be a potential for the future. I think it all, again, comes down to risk versus benefits. We know that there are potential for adverse events with this medication. And so whether a female would have, you know, symptoms significant enough to counterbalance that, it would be a super individualized treatment plan, but definitely something interesting for the future.
Is it fair to say that once you have one successful gene therapy treatment for a disease like this, that the pace of research should increase because it reflects a level of understanding of the mechanisms?
Yeah, that's an excellent question. And I really think that since gene therapy has come into this space in you know, neuromuscular and genetic disorders in general, we've seen just such an explosion of technology and improvement in our understanding of these therapies and the ways we can best optimize them. So I'm very hopeful that, you know, as we've gained this experience, we've learned more about how to manage patients who've received these medications and the potential side effects. And then, of course, our regulatory bodies have kind of learned a little bit about what this looks like as well, that, you know, we'll continue to see progress in this area, more approvals and expansion of these therapies to, you know, hopefully everybody.
Thank you so much, Dr. Batley, for sharing your insights and will hopefully become a major turning point in the treatment of DMD.
Of course, thank you so much for having me.
I want to thank Dr. Batley for her insights and Children's Health for their support of today's event. Now, before I welcome our panel, and I do invite them to turn their cameras on and join us on screen, I do want to say a quick note. For those of you in our audience who are live with us today, we do hope to make some time for your questions. So as you have those, we ask that you please type them into the Q&A feature in Zoom on your screen. Our team will review those, and I'll give voice to some of those as I can over the course of our hour. Now, I'm very pleased to welcome our distinguished panel of experts whose full bios you can find on our event website at usnews.com/events. With us today are Dr. Sandy Burns, a pediatric neurologist and medical director of the neuromuscular program at Phoenix Children's, Dr. Susan Iannacone, the Warren A. Weinberg Chair in Pediatric Neurology and Learning, and Director of Clinical Research for Pediatric Neurology at Children's Health in Dallas, as well as a professor of pediatrics and neurology at UT Southwestern. Dr. Peter Kang, a pediatric neuromuscular neurologist and physician scientist at the University of Minnesota, where he is director of the Greg Marzolf Jr. Muscular Dystrophy Center and professor and vice chair of research for the Department of Neurology. And Dr. Natalie Katz, an assistant professor in the Department of Pediatrics and Division of Neurology at Duke University, where she co-directs the Duke Children's Neuromuscular Program. Thank you all for making the time to be with us. We have a lot of ground to cover, so I want to jump right into the discussion. First, I wonder if each of you could all just kind of talk a little bit more about your work, the roles you have, and your institutions. Dr. Katz, maybe we could start with you.
Thanks for that introduction. I'm at Duke University, where I co-direct our pediatric neuromuscular clinic. We see a variety of conditions in our clinic. Most of them are pediatric onset, and we follow our kids throughout the lifespan, and have started the process of transitions, which I know maybe we'll touch on later, but I call them my kids who are not kids anymore, because it's been a changing landscape, as you've heard a little bit about. And so these kids have grown up in our clinic, and we continue to follow them, and we have been very active in the research space, and our families are very invested and well-versed at what's happening in the neuromuscular world with all the new treatments and therapies and things that are on the horizon. So we're a very active clinic in that regard.
Great, thank you. Dr. Burns?
Yeah, so I'm Sandy Burns, and I'm the director of the neuromuscular program at Phoenix Children's Health System. So we're providing pediatric neuromuscular care now for the whole state of Arizona, at a spectrum from newborn screening to late adolescence and early adulthood. We are also involved in a lot of the clinical trials for SMA and Duchenne's. We have dosed many kids now with the gene therapy that was alluded to. And I'm interested in the discussion because we certainly have a lot of things that are controversial and things that could help, change our treatment regimen.
Well, welcome. Thank you for making the time. Dr. Yannicone?
Yes, thank you so much for inviting me today. I have been at UT Southwestern now for over 30 years and running the neuromuscular program there. I'm now co-director with Dr. Batley, and I oversee the clinical research program for child neurology. So I've been involved in clinical trials in pediatric neuromuscular disease for a long time. Early on, it was mostly about SMA, and then more recently, Duchenne. And of course, the discovery of gene therapy for SMA was dramatic and has changed everyone's viewpoint of pediatric neuromuscular disease now.
And Dr. King?
Thank you. So I do research and I see patients in clinic. In my research laboratory, which has numerous talented individuals, we look at a lot of genetic issues that come up in muscular dystrophy, particularly for patients who don't have a clear genetic diagnosis. And we also look at mechanisms of disease and new therapeutic strategies. In our muscular dystrophy center, we're really developing a nice translational program where we take discoveries from basic science laboratories and bring them to the clinic. A good example of this is a study that we're opening up very soon, which is a stem cell-based therapy for Duchenne muscular dystrophy.
Great. Well, welcome to you all. And again, thanks for making the time. So neuromuscular diseases affect an estimated 41 out of every 100,000 young people under age 18, and they cover hundreds of debilitating disorders. You mentioned just several of them in your introductions. Because there's such a range of neuromuscular diseases, and I know it's hard to generalize, but I wonder if each of you could kind of talk briefly about some sort of breakthrough treatment or therapy or diagnostic approach that excites you, and what it means for the individuals and the families affected by a particular disease or diseases. Dr. King, actually, I wonder if we could stay with you, and I wonder too if you could speak a little bit about the universal newborn screening for Duchenne in Minnesota that's online.
Yeah, I'm very excited by all the new developments in newborn screening now. It's pretty universal in the United States to screen for spinal muscular atrophy. It's very widespread to screen for Pompe disease, which are also neuromuscular diseases of childhood. And the newest development is newborn screening for Duchenne muscular dystrophy, as you mentioned. Currently, there are 4 states that have approved DMD newborn screening, including Minnesota. We're planning to do a rollout in 2025 based on information I have from our Department of Health, and that's very exciting. The screening for Duchenne muscular dystrophy is a little bit more complex than with some of the other disorders. It's typically a 2-step process where we first screen CK levels in the serum blood spots. And then after that, if it's elevated, then we have to figure out a way to arrange for genetic testing. So it's a little bit more complicated, but there's a nice pathway forward, and I'm looking forward to more states implementing this as well. I know that other states are actively discussing initiating newborn screening for DMD.
Dr. Burns, is there something you'd like to share in terms of the breakthrough?
Well, I think that, the breakthroughs, I think that Barry talks about gene therapy and some of the other, gene therapies that started with, SMA. I think what's really exciting also, especially for people who've been doing this for a long time, like myself, some of the treatments that that are coming in clinical trials are available for older boys with Duchenne's. We're involved, and a lot of institutions are involved in some cell-based therapies that may help with cardiac dysfunction or upper limb dysfunction in older boys, new steroids that may, be associated with less side effects, and other medicines that are directed at muscle that are either anti-inflammatory or anti-fibrotic. I mean, there's a whole list of medications that are either cell-based or non-gene-based therapies that, are sort of under the radar, that are on the horizon.
Dr. Katz, anything you'd add?
Yeah, I mean, I just echo that. It's really exciting to see all of the different therapies that are on the horizon, and that some of these platforms, like the gene therapy platform, where we can tinker with what's on the inside of the package, or some of these other cell-based therapies where they're able to adjust the molecular conjugate, the little genetic piece that's going to go in and help affect the specific molecular change that's causing the disease. To see that those platforms are able to be effective across different therapies is really exciting, and it's kind of a step towards, precision medicine. We're really getting at the root cause of these genetic disorders and really making a difference upstream so that we can improve long-term outcomes.
And Dr. Iannacone, I wonder if you could help us sort of start to drill deeper into gene therapy. I know that's a promising avenue, and there's a lot of excitement that we've already heard about. Talk to us a little bit, if you could, about how you or if you are using gene therapy with patients or specific diseases, and what how this works and what some of the implications might be. And are you hopeful that this might be a game changer for many kids and families?
Yes, absolutely. So we have a gene therapy program here at UT Southwestern under the leadership of Dr. Stephen Gray, who is developing treatments for ultra-rare neurodegenerative diseases, some of which are neuromuscular. And we have been able to take his inventions from the laboratory to the clinic, and we've run 3 investigator-initiated studies here. One of the challenges, of course, is the expense of running clinical trials. And the patient and family community has been so successful in supporting basic science research. But then when that invention is ready to come to the lab or to the clinic, the cost of running clinical trials becomes prohibitive. So what I've seen is a tremendous process of learning on the basis in terms of the clinicians and the FDA working together in this rare disease space, where outcome measures are a huge challenge. And all of that work has come together to design clinical trials that are workable and successful. So even if you have a mutation that only affects a half dozen people in the world, it's now possible to take the drug development into the clinic with the help of the FDA and the patient community, which is really amazing.
Anyone want to build off of that, talking about gene therapy or anything like that? Well, maybe one thing I know I'm curious about, and maybe something that our audience would because they come from a range of different disciplines and specialties and institutions, the actual process of coordinating care across locations in the clinic, at home, at school, seems very daunting. And I know you all, that's something that all of you are navigating in a very individualized and way, I'm sure, with the children and the families you work with. Are there any kind of guidelines or lessons learned about what works effectively in terms of care coordination across, again, many different places and specialties and that sort of thing? Dr. Katz, maybe I could start with you, but again, welcome any insights from all.
It's a challenge. These families, these kids often come from communities where they're the only one in their community. People maybe have never even heard about their specific condition. They come from across the states or from neighboring states or from small communities where they have limited resources, both, the family themselves and the community themselves. And so we as a care center have to get creative in how we are able to provide care for them so that they can have access and that it doesn't put any additional strain on the family, or we try to minimize, what we're asking of them. And so our clinic does a lot of different things. We partner very closely with local therapists. Our therapists here at the clinic, who are very knowledgeable and see lots of patients and families with these rare conditions, will call local therapists and offer to talk through things so that the local therapist has some insight and some knowledge about what to do. Our team members will participate in IEP meetings and 504 plan meetings to share some of our knowledge and recommendations. We'll provide letters of medical necessity or recommendations to school systems or to what have you, so that they can just share that knowledge. We'll provide resources from many of the different advocacy organizations and connect families and communities to schools and therapists so that they can all have some of that information. And then we also partner with local pediatricians to get, standard labs, any kind of acute care needs, just again, sharing that knowledge base. We'll also partner with local specialists, that recognizing that it's hard for some of these families to make it to our care centers, but we don't want that to prohibit them from having access to care and receiving the best care that they can. And so we really try to do what we can as a care center to partner with our local communities so that the families can have what they need and not have to work so hard to get that.
Anyone else care to jump in, Dr. Kang?
Sure. Yeah, I agree that some of the coordination of care has been a longstanding barrier. Many academic centers and children's hospitals have multidisciplinary clinics for neuromuscular disorders, and they're very effective at providing high quality care. Even before the new wave of FDA-approved therapies in the past decade or so, these clinics provided care and improved outcomes for patients. And now the care has become even more complex and more exciting. The transportation barriers are considerable. These multidisciplinary clinics are far and few between in certain parts of the country, so access and transportation become major barriers. And that's compounded because some of the therapies that are available now for multiple diseases involve regular infusions, whether it's through an IV or sometimes even into the spinal fluid. And so there are questions that come up about how best to provide access and how best to provide equitable access to care in these therapies. And we tackle them on an individual basis, but some of our approaches are standardized.
Dr. Burns, you mentioned, minding the whole state of Arizona, which I know is obviously a big state, and Dr. Anacone for Texas as well. Wonder if you could kind of talk about that as well, or even share any insights you might have about how, about transition programs. That was alluded to earlier, and I'd love to start talking about that. But first on the sort of care coordination, especially across a wide geography.
I think the care coordination is a good point. And I think that virtually all of our panel here probably practice in this organization similar we do, that all of our care is mostly in a multidiscipline type of clinic where we have access to the subspecialists, the cardiologists, the pulmonologists, the therapists, the social workers. And most of these children are seen, at some interval where they don't have to travel multiple times for different doctor's visits. They're ending up in a every 6 months or whatever type of program. So coordination of care and multidisciplinary clinics, I think, is the way this has gone. We're talking a lot about gene therapy but gene therapy now is commercially based, and those children are treated as very similar to some of our research patients. So it becomes very tedious. And in our institution, they actually have a institutional readiness committee every time one of these big drugs gets approved to decide how we're going to handle it, where we're going to handle it, and whether we can handle the possible adverse effects that are known and maybe unknown. So it's actually a big process that's very involved, and it's not just getting a gene therapy and giving it to somebody. So it's quite complicated, it's quite time consuming, and it's very costly. Okay. So it's costly to the institutions. The patient's cost, though, I think is something that we haven't really addressed. And the patient's cost is not necessarily from the treatments. It's from the loss of employment, the loss of work, and an emotional cost that is, unknown. So long-term care in pediatric neuromuscular disease, I mean, is a big issue. And a lot of it is addressed, but there's probably a lot that's not addressed. But when you come to transition to adulthood, that's a code word in our division of independence. We worry really about making these children and adults independent, and we try to get them adult providers, but the ball game is to make them independent. So we start really early in adolescence. I mean, where they know their drugs, they know what they're taking, they know when their appointments are, and we try to bring them along to make their own decisions when they actually get to age.
Dr. Katz, I wonder, I think you mentioned it earlier, sort of the transition and seeing individuals age and past 18. I wonder if you could talk a little bit about that, what you've got going on at Duke, and any other sort of commonalities with what Dr. Burns just shared.
Absolutely. It has become more of a hot topic lately, especially if these have become available and these kids are living longer than we've ever seen them live before and doing things we've never seen them do before. And so now we're in this position where our kids are not kids anymore. They're growing up, they're living into their 20s and 30s and 40s longer than we've ever seen them live before. And so now we have to figure out, how do we continue to manage our kids who are older, along with all of our new kids that are continuing to come to our clinics and also need that care. And as Dr. Burns mentioned, it's this transition to independence. It's not the same as you're 18 now, go to the adult side and go see an adult provider. And historically, a lot of those providers didn't see these types of conditions in their clinics, again, because it wasn't something that was, these kids live long enough for them to see. And so the adult side has also had to learn how to accommodate these families, learn about all of these new therapies that they haven't historically provided before, or prescribed before. And so we've really had to work together with our adult colleagues to figure out, how do we do this? It's not just a number, it's really making sure that the patients and families are still going to be well cared for as they go through that aging process. And what that looks like at each institution is different. Here at Duke, we don't have a hard cutoff on when we transition folks. Other institutions do. We are lucky to have an adult neuromuscular team that has another similar multidisciplinary clinic, and in which case they're able to receive our patients. But that's not always the case at other institutions. And so it does become very challenging about, how do we prepare these older individuals to care for themselves and to make sure that they continue to receive the medical care that they need as they age? Because some of the things that happen as they get old, we just don't see as pediatric providers. And so at some point it does benefit them to transition over into the adult world because they do see things differently and care for things differently than we do on the pediatric side.
Yeah,
Dr.
I'd like
Iannacone, yeah, could you add a little onto this? If I remember correctly, it's something that you all are actively working on with Children's Health and UT Southwestern.
Yeah, so I would make two comments. One is I'd like to give kudos to the patient community because I think the patient community has been extremely active in this area. Most psychologists will say that if you want to teach an adolescent to be independent, you've got to start early by age 14. And we have a population of adolescents who are used to being dependent on caregivers and have not necessarily learned about autonomy, that they have autonomy in spite of that dependency. So the patient community, again, has been really very good about providing seminars and webinars, online materials for parents and families. And that has helped us, help the clinic team to implement a lot of those activities with the help of our social worker and child psychologist. The second comment I would make, as Natalie already mentioned, it is important for us as educators in the medical centers to make sure that our adult neurology trainees are getting the education that they need in terms of taking care of this population as they get into early adulthood. So the training programs have to change and are changing, and that's made a big difference. And of course, that leaves out the whole structural issues of insurance coverage, which is our other big challenge. But I think the patient community has been fabulous and our training programs are changing.
It's encouraging. Yeah, I think it's important that we move into the sort of cost and insurance conversation. I know that's a big challenge you all have alluded to, but I wonder if we could sort of unpack that a little bit. Essentially, cost, especially when insurers don't cover certain treatments or when working with payers requires significant extra effort on the part of families and clinical teams. What are some of the things that parents and pediatricians and others can do proactively to ensure the best possible care free of, major hurdles or disruptions? Dr. Kang, I don't know if that's something you could start comment on or.
Sure, I echo what Dr. Iannacone said about the amazing patient organizations that exist. Our relationship with patient organizations has changed pretty dramatically over the 20 years or so of my career, and they're very routine partners now in everything we do, whether it's clinical care or research. And I find it very useful to hear patient perspectives when I go to patient conferences and patients are up on stage and telling the rest of us what it's like to live with their disease and what their hopes are and what would be a meaningful treatment for them. And that helps inform us as we try to implement new therapies and with insurance companies, try to advocate for the patients and try to make sure that there's as much access as possible for therapies that we think will be helpful.
Anyone else want to jump in on the sort of cost and insurance and navigating that landscape? Anything that has been successful or kind of in further empowering patients and families there?
It certainly is a problem, and it's an inconsistent problem. Even with the same providers, it's the policies change, and they change so frequently, and they're not the same for every insurance provider. So it becomes very, very difficult. And again, you're talking about institutions that are involved in most of these appeals, and the physicians are involved in most of these appeals. So it's really very time consuming. And sometimes it just makes no sense. Right now, we're in a great period. It seems like we've had lots of authorizations very quickly for gene transfer therapy. All of a sudden, by the end of the year, we've got more patients we could handle, where, mid-year, we were having a lot of difficulties. So it becomes very problematic, and it's hard to plan your clinic, your time when things vary this much.
Dr. Anacone, were you going to add on to that or echo that?
Yeah, I was going to say that two very important members of our clinic team, of course, are the case manager, multiple case managers, and the social worker. And they're the ones that help navigate us and the family through all of these appeals and pre-authorizations. And it is challenging. Some of our patients most of our patients are on Medicaid, which in the state of Texas is managed care. And what that means practically is that one day we may be in network and tomorrow we may not. If the patient moves from one side of the street to the other side of the street, their policy will change. And again, we have the problem. UT may be in network and Children's may not be in network. It's really extremely chaotic. And so what that means is we just need more FTEs on our clinic team to help us get the patients the care that they need.
Dr. Kang,
Yes, I just want to add that to further develop this theme of communication, that I find in general that there is more communication among different stakeholders than there has been in the past, and that's really helping with insurance approval issues. Just as a general example, in clinic, we might have a therapy that's approved, but are having trouble, approved by the FDA, that is, but are having trouble for an individual patient getting coverage. And the patient really wants it, and the patient organizations are supportive of it. There are times when the insurer will say there's just not the data out there for this particular subpopulation. So then we can communicate with the manufacturer and say, these data are missing. And a lot of times the manufacturer is collecting that data already in anticipation of these questions, but they haven't released it yet. And the manufacturers nowadays are in touch directly with patient organizations, so they hear more directly. And I feel that they're trying to release data as rapidly as possible to help provide objective justification for wider approvals. And so I think that all helps. I think the communication among stakeholders helps a lot with the insurance approval issue.
Sort of broadening the lens to not just cost, which obviously is a huge element, but ensuring access to an equity of care. I wonder if that's something we could talk about for a few minutes. That's a challenge for so many. And again, managing care across entire states and wide geographies. Are there any sort of strategies or techniques that have been effective, whether it's virtual care or other sort of innovations from the last several years that have helped you all, navigating transportation challenges, for instance, or the social determinants of health? I wonder if we could kind of talk on that a little bit. Dr. Katz, not to put you on the spot, but anything you'd share there or...
Yeah, I mean, I think we use all available options when it comes to these things. And certainly, if a family is interested in some of these new therapies, a lot of times the burden of care and the requirements for monitoring can be very heavy initially. And so we have to work with the families, work with the local providers to find ways so that these families do have access and that they're not limited in their ability to treatment options just because of their geographic location or other components of health. And so we do utilize any and all option, whether it's a telemedicine visit, we'll send orders to a local lab, we'll partner with a local pediatrician, anything we can do to help increase access is an option for these families. And it really just comes back to making sure that they not only have access, but that we can do it safely. And that's really what we want to do for these families. And so those are just some of the techniques that we'll use. We also partner with our other colleagues around the state who are in the same space to see, can you help us? Do you have any local resources? So we really try and work together as a neuromuscular community as well to provide care for these families so that location isn't a barrier.
Dr. Anacone, I think one thing you all have tried, and I wonder if you could talk about it, is outreach programs. Could you help us understand that a little bit more and whether that's been successful or?
Yeah, so there are clinics across the country that have done outreach. And we wanted to try that because obviously Texas is a very large state. But to make a long story short, we were not successful. And there were a lot of barriers in terms of state regulation. There had to be, we would have to take the team like in a van and go to East Texas. And then when that didn't work out, then we looked at the virtual visits. So we were actually doing virtual visits through our NICU program long before COVID. And that was done, as Natalie said, that was a partnership between our neonatologists and the pediatricians in East Texas. And they had set up video connections with the NICU out there, and they had a really nice program going. All the billing was set up, but when we tried to do that for neuromuscular disease, we ran into too many barriers trying to find a place where the patient could go and a provider out there who could help us through the virtual visit. Well, then COVID came along, and during COVID, it was exciting to me to be able to see what we could do remotely. On the other hand, there was a lot that we could not do remotely. The neuromuscular exam really requires hands-on, in-person work, and so we have not been successful through our program to do outreach, but I know that other programs have been.
So
Yeah, Dr. Kane.
I can add that I agree that remote assessments, virtual visits have been very helpful over the past few years as that's become more mainstream. And that helps us both with providing clinical care and also for certain types of research. There's a lot more activity around doing remote assessments as part of clinical trials. And that's sometimes an alternative way, at least to do some of the study visits. But the in-person visits, it is difficult with transportation. One change that I've noticed over the past decade or two is that this issue is getting more attention, and we're seeing that funding agencies are more open to the idea, at least for clinical trials, of providing at least some travel reimbursement to families who have to travel long distances, and that's providing some better access. So yeah, there's still a lot of room for improvement, but at least we're recognizing the problem and we're coming up with strategies to deal with it.
That's encouraging to hear. Our time is winding down, but we do have some audience questions. I want to make sure I make time to ask one. Someone in our audience writes, and forgive me if there are details missing. I have a patient who has been on edapleurin, I'm not sure if I'm getting that right, therapy for many years. He's been wheelchair bound for about a year. Could he be treated with gene therapy? Would he need to be weaned off of that initial therapy prior to gene therapy? Is that anything you all might be able to share? Again, minding that there's limited details.
Go ahead, Dr. Burns. I think
Was
Yeah,
the
Dr.
drug
Burns.
Adlern? Was that the drug?
eteplirsen.
Eteplirsen, thank you.
So the answer is that I mean, there are lots of individuals who've been treated, including in our program, who had been on eteplirsen prior to receiving gene therapy. You know, the gene therapy for non-ambulatory boys, the gene transfer therapy that's approved right now is an accelerated approval, which means that you know, it's very difficult to get authorized. There may be more side effects. I mean, so in theory, yes, but difficult question.
I think one other question, and it's sort of a theme of some of our audience questions is just, Dr. Kang, I think you mentioned earlier about patients as, routine partners here, as well as, case managers and all the different stakeholders we've talked about over the course of the hour. Are there any sort of specific words of advice or calls to action for any individual who's part of sort of this care journey or life journey here? Anything that you approach in philosophically in your practice or anything like that, as we draw toward a close? I wonder if there's something we can kind of you all could reflect on there. Dr. Kang, perhaps you first.
Sure. I think what I've come to realize over the years is that sometimes patients' hopes and expectations can be different from any preconceived notions that I have. So I make more of an effort as my career progresses to trying to wipe preconceptions out of my mind as I approach a patient and really try to listen to what they have to say. There are lots of questions that come up, options that come up, whether it's therapeutic options, what a patient expects from a therapy, how a patient defines a cure can vary from one patient to another. And then the issue of independence, which has been brought up before by other panelists. There are some patients who, when they reach adulthood, they really want to live independently, and that's a major goal for them. And there are others who are more concerned about that. And there are also medical issues that come into play. But there's a lot of variation between patients, I've noticed, in terms of a lot of these decisions. And as they get older, progress through childhood, they want more of a voice. So those are some of the lessons that I've learned over the years.
Yeah, I'll just echo that a lot of our kids now who are growing up and doing all of the things, one of those things that they may have not had the opportunity to do before is go to college. And so when I'm talking with my adolescents, I say, you can go to college and you can live away from home, away from mom and dad, and start to gain some of that independence that other neurotypical children may have, or, thinking about, wow, I can really have a job. I can be a productive person in society and in this community. And I think those are things that many of these kids, as they're growing up, don't realize. And so it's really a source of joy for me when I tell these families, like, you can go to college, you can do all of the things that you want to do. And that's what our team is here to do, is to support you in whatever that dream might look like for you. And just like Dr. King mentioned, it's different for every person. And if that's what they want, then our team is here to support them. And so that has been really eye-opening to me to share with them, like, whatever you want, we're here for you, we'll support you.
Well, I want to move us toward just a final comment from everyone. And again, I think we've covered a lot of ground, though there's obviously we could dive into this for much longer. I guess I wonder if I could hear from each of you, kind of any final takeaways, whether that's something we haven't discussed or that you want to sort of double down and further emphasize from what we've spoken about. And in particular, I wonder if you have any sort of final takeaway for leaders in the healthcare community, whether they're your peers in practice or healthcare leaders at children's hospitals or other healthcare systems across the country. Maybe we can just kind of, again, go around the horn and hear from each of you. Dr. Katz, let's start with you.
I think it's a ever evolving landscape. So keep your eyes open and ears open, and don't take no for an answer, because the payers like to try and tell us what we can or cannot do, and I have other words for them. So it's don't give up. We can make it happen.
Dr. Burns?
Yeah, I've been impressed on how much support you need to take care of these individuals. So I think that having an institutional back you and absorbing a lot of the cost and energy makes this easier. It's not something any individual can do. So we will be there, but there's a lot of, it takes more than a village.
Sure. Dr. Anna Cohn?
Yeah, absolutely. We keep using the word team. It takes a team or a village to make this happen. And as far as the institutions are concerned, don't be penny wise and pound foolish, because there's so much value added. The outcomes are so much better for our patients and their families.
And Dr. Kang, any final thoughts from you?
I'm very excited about the future. We have the capability to do so much more. A lot of the science is there. A lot of precedents are being set, landmark discoveries. We just have to figure out how to accelerate these discoveries and make them more accessible to more patients. And so I have a lot of hope for the future. And I think if we look at system-wide issues, that can help a lot.
I'm grateful for all of your time today and for all the work that you do in moving this arena forward and at your institutions. I want to thank Dr. Sandy Burns, Dr. Natalie Katz, Dr. Susan Ayana Cohn, and Dr. Peter Kang for taking the time to be with us today. Thank you to those of you in our audience, including those who submitted some really good questions. And I hope you can join us again for another virtual event from US News. Visit usnews.com/events to see videos of sessions, including this one that you might have missed, as well as some upcoming sessions we have on our calendar.